All right, let's jump right in. Today we're going to do a super high-yield review of aseptic bone necrosis eponyms. We're going to focus on the key facts you absolutely need to know for your clinicals and, of course, for your exams. So let's get into it.
So, first things first, what are we even talking about? Aseptic necrosis. At its core, it's a blood supply problem, plain and simple. Imagine a part of a bone just isn't getting the blood it needs. What happens? Well, the tissue dies. It's also called avascular necrosis or osteonecrosis, and this whole process can lead to these tiny little fractures, and if it gets bad enough, the bone can literally just collapse. So, what causes this blood supply to get cut off? Well, it's not just one thing. It can be a whole bunch of stuff. You've got trauma, like a bad fracture or a dislocation. Then there are metabolic issues or even blood disorders, like sickle cell anemia. And, this is a big one you can't forget, sometimes we cause it. It's iatrogenic, meaning it's from medical treatment, like high-dose steroids or even complications from dialysis. Okay, let's call it a clinical tour of these different eponyms. We're going to start with the upper limb, and pay close attention here, because this is all about pattern recognition. You got to connect the name to the location and the type of patient you'll see. That's the key.
First up, we have Morbus Haas, and Morbus, by the way, just means disease. This one hits the head of the humerus. In the early stages, you might get away with conservative treatment, but if it gets advanced and that bone starts to collapse, you're looking at surgery, either a hemiarthroplasty, where you just replace the ball of the joint, or a full-on total shoulder replacement.
Now, this is super important. The key thing you're going to look for on an X-ray is the crescent sign. See that little line of clarification under the bone? That's it. It's basically a dark line that shows a fracture right under the cartilage. It's a pretty late sign, but when you see it, you know that joint surface is about to collapse. It's a huge red flag. Okay, moving on down the arm to the elbow, we have Morbus Panner. This is a classic one. It affects the capitulum, and you'll almost always see it in young boys, think 6 to 10 years old, who are super active in sports that involve throwing. So what's the deal here? It's all about repetitive microtrauma. That little capitulum in a growing kid just has a really delicate blood supply. All that stress from throwing puts pressure on it, compromises the blood flow, and bam, necrosis. It's a perfect example of an osteochondrosis. Now, let's head to the wrist. Here, the big one is Morbus Kienböck. This is the most common AN you'll see in the wrist, and it targets the lunate bone. Your patient's going to complain about chronic pain and stiffness. Treatment, well, it depends on how bad it is. You start with just immobilizing it, but if it's really advanced, you might have to do surgery to try and get blood flow back, or even salvage the joint. And this is a fantastic example of why anatomy is so important. The lunate bone is just unlucky. It has this really fragile, kind of backwards blood supply. The vessels feeding it are tiny. This makes it super vulnerable. Even a minor injury can be enough to disrupt that blood flow and cause avascular necrosis. All right, let's switch gears and move down to the lower limb. Now listen up, because there's a really important distinction we have to make here. We need to separate the true osteonecrosis, where the main problem is the blood vessel, from something called an apophysitis. An apophysitis is more of a traction injury at a growth plate. It can lead to necroses, but that's secondary. Knowing this difference is huge for your exams. Okay, down in the pediatric foot, we've got Morbus Köhler I. This one involves the tarsal navicular. And look at that patient profile. See a pattern here? It's another one you'll see in young boys, typically between 3 and 8, who come in with a limp and pain in the middle of their foot. Now, here's the good news. The word necrosis sounds scary, I know, but for this one, the prognosis is actually excellent. The main takeaway is that you treat it supportively. Immobilize it with a cast or a boot, maybe use some arch supports to take the pressure off. You just give that navicular bone time to heal itself, and it usually does. All right, next up is Morbus Köhler II. But wait, don't get it mixed up with the first one. This is also called Freiberg-Köhler disease, and it's in a totally different spot. This one hits the head of the second metatarsal, so the pain is going to be in the forefoot, right there at the base of their second toe. And here's the other huge difference from Köhler I. Look at the demographic. It's a total switch. We're now talking about older patients, typically adolescent females. Seriously, being able to tell these two apart based on location and patient profile, that is pure classic exam gold. Okay, moving up to the knee, we have one you've probably all heard of, Morbus Osgood-Schlatter. This one is super common. You'll see it in active adolescents, especially when they're hitting a growth spurt, and they'll point right to that bump on their shin, the tibial tuberosity, and say it hurts right here. So remember what we talked about just a minute ago? This is a perfect example of that apophysis. Osgood-Schlatter is not a primary blood supply problem like Kienböck's. It's all about traction. The quad muscle is pulling and pulling on that patellar tendon where it attaches to the growth plate. This causes tiny little fractures, a lot of inflammation, and yeah, sometimes you get secondary necrosis of those little bone chips. And our last stop on this tour is the heel, with Morbus Haegland-Sever. You guessed it, it's another classic apophysitis. This time, the action is at the back of the heel. It's inflammation of that growth plate on the calcaneus, right where the big Achilles tendon hooks in. The mechanism here? It's pretty much a carbon copy of Osgood-Schlatter, just in a different location. It's all about repetitive stress on a growing bone. You see this all the time in kids between 8 and 14 who run and jump a lot. And the treatment plan? Exactly the same. It's conservative. Rest, ice, stretching, and basically just telling them to take it easy for a bit. Okay, we've covered a lot of ground, so let's pull it all together and boil it down into a final, high-yield summary. These are your take-home messages. Think of this table as your ultimate cheat sheet. It's got everything we just talked about all in one place. The name, the spot it hits, who gets it, and that one key thing you need to remember for each. I'd seriously recommend pausing here, maybe even take a screenshot. Really lock in these patterns of age, gender, and location. Okay, let's put this into practice with a quick case. You've got a 14-year-old female basketball player. She comes in with chronic anterior knee pain, and it's right on her tibial tuberosity. So based on what we've just discussed, what should be popping into your head? Well, the most obvious answer for that specific pain is Osgood-Schlatter, right? But what's the other condition we talked about that hits this exact demographic, active adolescent females? That would be Freiberg-Kohler disease. Now, yeah, that one's in the forefoot, not the knee, but connecting these patient profiles to the right diagnoses, that's what being a great clinician is all about.